As you heard, I'm Stephen Samus, Vice President of Programs at the Canadian Foundation for Healthcare Improvement, here today in a warming up Ottawa, which is terrific. It's my pleasure to welcome all of you to this informational call for the Better Health at Lower Costs for Patients with Complex Needs, which is an IHI Collaborative. We're very excited to be holding the call today with our friends from the United States, from IHI. Today we are here to answer your questions about the Better Health and Lower Costs Collaborative. We're going to describe the IHI methods and content to be used in the collaborative. We're going to describe the activities for the collaborative, as well as the application and selection process for the Canadian teams. On our faculty and on our call today, we have Corey Seven, Director for the Better Health at Lower Cost Collaborative, who I believe is in Boston today, and John Whittington, the faculty for the collaborative and the co-founder of the IHI Triple Aim. John is in Chicago today, as well as faculty for the collaborative, Catherine Craig, who is joining us today from France. Once again, we are absolutely delighted at CFHI to be working with the IHI. Very briefly, CFHI is a national organization funded by the Government of Canada. We have a mission to accelerate healthcare improvement for Canadians, and we do that by working with teams from across the country to improve healthcare and ultimately the health of Canadians. And so it's just a real natural fit for us to be working with IHI and to be really focusing on the content that's the nature of this collaborative. Also, as you can see here, our corporate goals are the goals that we hope that Canadian healthcare organizations can achieve, which is to maximize the value for money in healthcare spending, to improve patient experience and outcomes, and to provide a more coordinated approach to the complex health needs facing Canadians and facing our health systems today. And so this collaborative speaks perfectly to those goals and to the things that we're trying to achieve together as Canadians to improve the sustainability and the quality of our health system. This upcoming collaborative with IHI builds on previous work that we've been doing with the Institute for Healthcare Improvement. We've been supporting 9 Canadian teams through the current Triple Aim Improvement community, working with many of the same faculty and staff at IHI. We know they've had a fantastic experience going through the Triple Aim Improvement community, and we're equally excited to be working with the IHI once again and to be supporting Canadian teams into this new collaborative that really picks up on the great work that IHI has done for many years now on the Triple Aim. So I'm going to turn it over now to Catherine to explain to us why this, why now? Why this collaborative, why now? Catherine.
Great. Thanks so much, Stephen. Happy to be here with you all. So I think, as you all know, healthcare is accounting for huge chunks of national spending. And at the same time, more and more there's a realization that the high cost of care for people with complex needs who are driving large chunks of healthcare costs, the health outcomes that group of individuals are achieving don't align with the amount of spend. So that speaks to a need to try to figure out how to do something differently. And what we've been doing through the course of the Triple Aim is working on ways to improve the health of a given population while improving their experience of care and driving down the cost of care. You can imagine doing things that would really benefit people's experience of care but drive cost very, very high up. What we're trying to do is keep those three in balance. And what we understand is that we can achieve the Triple Aim by learning how to redesign care for this top 1 to 5% of people who, one way of thinking about them is that they're a really high leverage group since there's so much money wrapped up in their care. So if we figure out how to work with them, we'll likely move the arc of costs in the whole healthcare system. So how does this make sense in Canada? With healthcare consuming 40% of provincial budgets, there's clearly no more money that's coming into the healthcare system. So we need to be creative to find new ways to serve the people with the highest needs, as we're mentioning. And what we're going to be sharing with you today is some programming that we've developed to do exactly that, to figure out new ways of serving these folks. So in terms of another way of thinking about this in Canada, we know that 1 in 7 of the 16 million Canadians who live with chronic illnesses have at least one what we're calling a high-impact condition. So in Canada, as in the United States, you see waste as people across the board use the emergency room unnecessarily, or access care in ways that are high cost. So what we're going to be working with teams to do is figure out ways to reach people with complex needs so that they're able to get their care in the community in lower cost forms of care, which at the same time impact their health outcomes much more positively than when they go into the ED to get one or another challenge taken care of, basically. So what does this look like so far? This is a snapshot of programs across the U.S., Canada, and a little bit in Western and Northern Europe who are taking part in the Triple Aim right now in what we're calling the high-risk, high-cost work group, which is the group of teams whose work is really leading in a beautiful evolution towards this new collaborative that we're launching in the summertime. So John is going to be able to speak with you in some more detail about what this programming looks like. But what we're offering is that we'll be able to guide you to transform care, to be able to use tested interventions that we've worked with teams over the last several years to figure out how to better reach these folks with complex needs. And these interventions have already boosted health outcomes, driven down costs, and improved people's care experience in programs across the U.S., Canada, and Europe. So it's good work that we'll be sharing with you that we already know is having some great impacts. So the slide we're looking at right now, it just helps us to understand a little bit what the cost profiles look like. And so we know that 22% of people, this is U.S. data, of course, 22% of people end up in that top 1% of the cost profile in a given year. And 50% of people end up in the top 5% of cost. The challenge is that we know that only a small number of those folks are going to be in the top 1 or 5% next year as well, because some of the high-cost conditions are going to resolve themselves, cancer or work to the people who have the most complex needs over time. And when we figure out how to do that really well, the work reaps very large dividends, both in terms of cost, but also in terms of improving health outcomes. And here we're looking at just another way of taking a look at what the cost profile looks like in the U.S. in the publicly funded Medicare system. Just another way of looking at that the top 1%, here it's the top 5% of people using the care system account for almost 50% of overall healthcare expenditures. And with that, what I'll do is turn it over to Stephen to be able to look at what some Canadian data looks like as well.
Thank you, Catherine. Well, interestingly, it's quite similar in Canada as it is in the U.S. and elsewhere, where a small proportion of patients consume the majority of healthcare services. This slide was created by the Institute for Clinical Evaluation Sciences in Toronto, and you can see here that for Ontario, on average, healthcare spending is highly concentrated, with the top 5% of the population, ranked by cost, accounting for 66% of the expenditures. So very, very similar from that slide we saw from the Centers for Medicare and Medicaid in the U.S. And we've also seen that in Ontario, 5% of healthcare users consume 61% of hospital and home care spending. In British Columbia, 5% of healthcare users consume 30% of spending on physician services. And in Manitoba, similarly, 5% of prescription drugs accounted for 41% of prescription expenditures in the province. So again, we see this concentration of a small percentage of patients consuming a significant amount of the resources in the healthcare system. And then we also really need to be cognizant of the fact that in Canada, surveys by the Commonwealth Fund, the OECD, other international surveys and comparisons have shown that there is room for improvement in Canada. We have the opportunity to get better value for the dollars that we're spending on Canadian healthcare and to provide much better care at the same time. So that's what this collaborative is all about, trying to move those numbers on the Canadian outcomes and move ourselves closer to the top. John, we'll turn it over to you now to talk about some of the guiding principles behind this collaborative.
Great, thanks a lot. Just sort of in summary, there are a set of principles here that I want people to think about because all of the developed countries of the world have some level of concentration of spending. The slide you saw from Ontario is actually more spectacular or more concentrated spending than I've seen any place so far in terms of such a certain small population consuming a huge amount of resources. And it's not that we don't want that population to consume the resources. We know that in that population we've got some very, very sick people. The question we're always asking ourselves is, could we do a better job? And the answer is yes, we can. Any place in the developed world we can do a better job. So there's a few principles, though, that you need to think about as you do this work. One, you're trying to identify high-risk people for future cost. So it's easy for us to go back retrospectively and develop our diagrams and say, well, these are the people that cost a lot last year. The question is, can you do that for the future? So that's one key piece. Secondly, even if you identify those people, is it something that you can make a difference on? Some things, they're getting perfect, I'll say it this way, they're getting perfect care. There's not a thing you can do differently. There's no alternative to what they're doing. And so there's very little ability to impact that. But there are many, many opportunities where we have the opportunity to impact. So as you start to think about individuals you want to work with, you say to yourself, who are they? Can I make a difference with those individuals? The third thing, and if you don't remember anything of this call, it's about cost effectiveness, or another way to say it is sustainability. It's easy, it's very, very easy to put resources to try to improve the outcomes for these individuals and to improve the outcome, but to do it in such a way that it's cost prohibitive. So you always have to think about, can I do this in a cost-effective way such that I save enough money from the program I'm implementing that it allows me then to reinvest that money in the program going forward, that it's not chewing up more resources than we're presently using. And then the potential intervention or redesign, what are we currently doing isn't working, okay? Let's agree. What we're doing right now isn't working ideally. We could do something better, so how are we going to change it? My next slide is so basically I want you to, those are some principles. In the work that we're going to do together, basically we're going to do, there's two things I want you to remember. One is the content. What is it that we're going to work on together? And then the other thing I'll talk about is how do we actually do our work together? So it's enough to say, well, these are the principles. Here's what we're going to focus on, but then how do we make progress in it? So what I'm talking about now is what are we going to do together? What is the areas that we're going to focus on? And what we're going to help people do is identify who are the high risk. So thinking about who is that in your population. Secondly, after you've figured out who the population is that you want to focus on, you'll have to figure out some care system design. There's basically two models out there. One I'll call the ambulatory ICU. That's a model in which you usually have a primary care physician who's seeing just a few hundred patients, not the typical size practice. And these patients are the sickest of the sick, and then you're wrapping some other resources with them. There might be mental health resources, there might be social service resources. Altogether, it's again, it's sort of an ambulatory ICU in which it's rich with resources, concentrated on people who have significant healthcare needs and spend. Another model, though, we see in parallel to the primary care team, but the primary care team hasn't really changed. The primary care team is still seeing the usual volume of patients it has, but these individuals, these high-risk individuals, are being supported by some other resource, and I'll call that wraparound. And these are basically caricatures of the models, but those are the idea behind them. The next thing that we focus on is how do you actually recruit people into your various care system design. Then we talk about how do you actually engage people, because they'll obviously have to be deeply engaged in this transformation. And finally, we talk about community support. So what is it that you need to engage with the community to support these individuals? I'll tell you, basically, if you think that healthcare itself can do the work, you will fail. These people are challenged often not just on the medical issues, but on mental health issues, on social issues. There's a variety of things. And so when you approach this work, you have to think more holistically about that. Here's a nice slide. One of our present Triple Aim sites is Edmonton, and they've been working with us on this for a couple of years now. And one of their focuses is the high risk, high cost. And so in the particular population of 79,000, that's the total population, they have approximately, who they've identified as 4,623 high-risk individuals. And then what you're seeing in the diagram here, in the pie, is the percentage of, these are all high-risk individuals, and then they cluster into these 6 groups. 1, 2, 3, 4, 5, 6, yeah. So you have elderly with chronic disease, that's one big group. You have mental health and substance abuse and chronic disease, that's another big group, and you can read the others. When you do this work, you tend to focus on a particular population. You aren't probably, at least in the beginning, going to tackle all of these populations at once. And the systems that you design may be different. Obviously, something with mental health and substance abuse is probably going to be different than complex infants and toddlers. So you actually have to think about where is the money and where do you want to really focus as you think about this. So I said there are basically, what is the content? I just mentioned what the content is. It's about identifying the population. It's about understanding your care model. It's about engaging the population and recruiting the population and working with the community. Well, that's all great. That's nice. But how do you actually get started? And here's how we actually help people to get started. We actually help them identify their high-risk population. We help them dig down to understand the needs and root causes in this population. We actually say to them, then the next thing we want you to do is plan and work with it, just a few people, just to start to learn your way through it. And then finally, after we've done steps 1, 2, and 3, we can really get back into that content area. We have quite a bit of knowledge, and at IHI, we like to learn our way through things. We don't like the people to do a design for a year, implement, and fail. We like to do some planning. We like to do some testing, and then move forward on the implementation strategies when we have a good set of knowledge behind it. So then what we'll do is we encourage people to scale up to 25. If you're already working with 25, then we ask you to go to 125. If you're at that level, then we ask you to go to 625, et cetera. We'd like to jump by 5, by multiples of 5, to help you learn your way through this. And that's sort of how we work together. And then as you're at the level of working with 25 or 125, the issues that are going to come before you are other structural issues. So information technology, human resources, physical aspects, funding aspects, learning system. You have to put these together. You have to think, what does that mean for 25 individuals, if we're working with them? What does that mean for 125? What does that mean as we move up higher? And in fact, the next slide illustrates, it's an eye test for you, don't worry about it, but it's actually a detailed plan that one of our sites has put together. One of the faculty actually has put together who's doing this work, about how they thought about the care model when they were working with 25, how they thought it at 125, how they thought about it at 625. And they didn't know all this at the beginning. They just probably understood the 5 to 25. And after they worked on that, they started scaling up to the 125 and to the 625. It's a way that we think it's important to learn your way through it. I know I'm going a little bit quickly for you today, but the idea on today is just for you to get a sense of what we're really going to do together. What's the substance behind what we're talking about? Here's a set of measures that we will have you work with on these populations as you think about the Triple Aim for this population. What does population health look like for this? What does experience of care look like? What's per capita cost look like? And then there's a set of measures proposed and data sources. We've been using these measures for years. We've been working with organizations for years, helping them think through where can they find the data and how can they measure it for their particular population. And then let me just finish up now with, here's a slide of some nice work that one of the organizations has done, Care Oregon, in which they're focusing on high-risk, high-cost individuals, and they have a program in place, and they're showing you the per member per year hospitalization rate, the inpatient rate. and what it was pre and what it was post. And then the same thing on per member per year emergency room rate, what it was pre, what it was post. And what you're seeing is some nice intervention and some nice change. But remember, the things that should be going in your mind when you see a graph like this are, is it impacting the whole population? Have they done this cost effectively, et cetera? So those are the kinds of things that you need to think about. With that, let me turn it over to Corey.
Thanks, John, and hello, everyone. Really happy to be here with you today. So just kind of in summary to what John has said, in our collaborative, what we want to do is help people plan and really learn your way to understand care models that will serve the needs of the population that you identify as high risk and high cost, get better health outcomes, better care experience, and total lower cost. And we care a lot about helping people learn to do it in a way that it's going to be sustainable. So we want to make sure through measurement and good quality improvement methods that you know that you're getting the impact you want on for your individual patients and the population segment, but also lowering cost, and that you have a sustainable model, that the intervention that you believe is going to make an impact for your patients that you'll be able to afford. Because we know that things can be better, and we don't need another project. We really need to learn, all of us, how to bring programs to scale in a really sustainable way so that we can really make a lot of progress. And John alluded to this as well, whether you're an organization that's just getting started and the steps that he outlined will be new to you, or whether you're an organization that already has services, maybe you already have 50 or 100 people in your program, or 250, we are prepared to work with you to ask you to do some work to go back through those steps to just refine and make sure that you have all the detailed knowledge that you need to go to full scale, and then we will work with you to really get to full scale so that and learn your way operationally to understand what it takes to really serve 100, 200, 2,000 high-risk patients, whatever your numbers are. So that's really what we're about. The activities of the collaborative are here listed on this slide. It is a 12-month learning collaborative. We are tentatively planning a second year just because we believe it takes a long time to do this and to build the learning and the infrastructure. We think it would take about 2 years for an organization just starting out to really develop their care model and understand the operational implications to go to full scale. So we're tentatively planning a second year. We anticipate 30, probably 40 organizations, and are really excited about Canadian teams joining us as well, because you all definitely add to the learning experience for all of us. We'll have 3 learning sessions, all-day learning sessions. One will be face-to-face, probably in February. We're definitely shooting for someplace beautiful and warm, something that we'll all enjoy. The other 2 learning sessions will be virtual, all-day learning sessions. We'll have bi-monthly community calls, so calls twice a month, and we also have a separate measurement track led by Kevin Nolan, our improvement advisor, to work on measurement, just because that's really data and measurement in this whole area are quite challenging, and there's lots to learn there. We will, of course, use quality improvement methods, the model for improvement, and rapid iterative learning, and help develop your skills and capability in those areas. We have a measurement strategy. We will have reporting, which will be every other month. Definitely reportings and looking at data is a key part of learning, but it also is a burden, so we will have every other month reporting, and we will start in July, so this coming July. So that's the activities of the collaborative. And on this slide is what we promise will be accomplished. So first, and really these are reiterating the steps that John talked about, but really understanding and identifying your high-risk, high-cost population and doing the good, thoughtful work of trying to understand to the best of your ability who's going to be high cost in the future. to deeply understand the assets and needs of the population based on their experiences, and to test interventions that you will come away with confident is going to impact their behavior. Co-creating and executing new care designs, so coming up with that care model that you feel confident is going to have the impact that you're wanting, both on health and experience, but also cost. And then John talked about going to scale, that we will work with you wherever you are in moving to scale, and with a particular eye on sustainability and understanding the operational infrastructure that's going to be needed to be successful. All right, so here's some pictures of our faculty. I've got Catherine here on the phone today. There's me in the middle and John to my right. Kevin Nolan is our improvement advisor and has been one of the thought leaders in the Triple Aim in this work now for years. And our other faculty are also incredible. They are working on the ground now for years in this topic, and so they bring that really frontline experience. Alan Glasseroff and Ann Lindsay are physicians at the Stanford Coordinated Care Clinic, and they've been working in this area really for many, many years. Rebecca Ramsey at Care Oregon has been one of the key faculty and key learning drivers, I guess I'll say, in the high-risk, high-cost work group and the work they're doing at Care Oregon. All right. So I think at this point I'm going to turn this back over to Stephen and talk about who is great to participate in this collaborative from a Canadian perspective.
Thanks very much, Corey. Well, as you can see here, definitely those organizations who are providing care for complex high-needs patients and high-risk population groups, we would highly encourage you to consider applying for the collaborative. We also really encourage those Canadian teams who are currently in the Triple Aim improvement community to reapply and continue the work that you've been doing through the course of this new collaborative. And I think the other thing to consider is for those teams on the line who are really interested in a process and a methodology to really help build your capacity to understand and to implement the Triple Aim approach in your organizations. And importantly, to use this approach to build partnerships with others in your community to really, the kinds of partnerships that are necessary to really address the needs of high-risk, high-care, complex care populations, and to really improve the health of those populations. They often take intersectoral collaborations, and this process is an excellent way to build those connections and build those partnerships and improve care. So the process for applying to for the Canadian teams to apply is actually quite straightforward. The first thing to do is to visit our website, and the link is here as you see on the slide. And then also, please send us an email to express your interest in the Triple Aim opportunity and the collaborative. Then what's going to happen is we're going to be working with you to hold informational calls. There will be all of the teams who contact us. We will hold an informational call with CFHI and IHI staff. And after that, we will get back to all of the teams and identify those 10 teams with whom we are looking forward to partnering to cost share the fee that will cost share the fee for entry into the collaborative. So the fee to join the collaborative is $20,000 US. CFHI will provide half of that support in the amount of $10,000 US for teams who are interested in able to go into the collaborative. So we will be looking forward to having those calls with you to gauge your readiness to enter into the collaborative and our opportunity to work with you as you go into the collaborative. For those teams that are on the call today and perhaps aren't selected as one of 10 that we are cost sharing with, there's nothing to stop you, of course, from applying directly through IHI and going into the collaborative on your own. So once we have the informational calls, and we get going, when we start transferring the money, all of you will get working with the IHI as of July 15th. So that kind of gives you the time frame between now and July 15th. So we now have an opportunity here to take questions, and I'll try to answer some of the ones that are most relevant for us, and IHI friends, we'll ask you to pick up on some of the others. So we have a question here from Marilyn saying, do we need to have identified our population prior to having the initial call? And how about John or Corey on that one?
We would like you to, the answer is no. We would like you to be thinking about the population. And as if you go back to that Edmonton slide, we don't have to do that now, you'll see that there actually are a variety of populations that you could be thinking about. So we want you to be thinking about it, but that's part of the work we're going to actually do together is to help you say, okay, this makes sense. But everyone, I'll just say it this way, we want you to think about it now. What makes sense for us as an organization? Which population is the highest need for us now? Where should we concentrate resources? What makes the best financial aspect for our organization at this moment in time?
Great. John, I have a follow-up question for you that some of the teams on the line may be thinking, and that really is based on your experience with the Triple Aim, and in maybe perhaps drawing on some of the experience of the 9 Canadian teams that are in the current Triple Aim cohort. What do you see as some of the real criteria, the essential criteria for success? What do teams really need to have to be able to do and have ready to go by the time they start the collaborative on July 15th?
Well, I think that's a great question. I mean, that's a terrific question for any of these kind of projects. I'd say the following. First of all, this is strategic work, so leadership really has to sign off on this, if you will. This isn't some little bitty project. As you saw from the Ontario data, huge concentration of spending among these folks, and if you get the cost under control, it's going to have huge ramifications for the community, for the province, etc. So this is big time work. So I'd say first, we should have leadership on board with this, that they see this as a priority and they see this as a huge opportunity. Second, I think what we'll have you do is we'll want you to make sure you have some sort of clear day-to-day person who can actually help work on this. Again, if it's strategic, this is not some little minor thing that's off in a corner. This is a big piece of work for the organization. And then I think, it still will come down to, do you have the ability to actually start working with individuals, and we'll call it learning our way through this. Now, we're going to give you a lot of information, so it's not like you're starting from square one, but still, when you choose a population, you have to know their needs. We're going to teach you how to really understand their needs, and then we're going to really work with you. But in the end, the teams that are successful, I'd say they have good leadership ability. They have someone who's really driving the work, and they have some ability to learn their way through it. They have some ability, they have some capability on quality improvement and what that really means and how to actually do this work. Teams that don't have that good alignment, et cetera, they often struggle. They like to do a lot of planning, but they don't do too much action. So that's just sort of a summary of the kinds of things I think about.
Great. Thank you, John. Another question here from Mary, wondering about the applicability of the collaborative for, say, people living in long-term care, or is it really an acute care-based collaborative?
Oh no, this has, how can I say, this has very little to do with acute care. This is about managing populations, specifically at high risk, and I'll say it this way, and it may be a little harsh, but sort of think of when we have acute care, that it's been a failure of care, and how do we rescue that situation? I'm a family doctor by training and practiced for many years, and the way I like to think about this is maybe we identify some of those people in the emergency room or we identify them in the hospital, but the real work is upstream work for these individuals, and it's not a simple thing. Do this one intervention and you will be good. It's a series of interventions, a series of working with both social, behavioral, and primary care to support these individuals to prevent. In those examples, those slides I used where you saw the spectacular decrease in inpatient utilization, that had nothing to do with the hospitals. That had everything to do with community resources and community outreach workers that they were using to actually support people in that particular population who I would say had a lot of mental health and medical disease. Hopefully that clarifies it.
That really helps clarify things a lot, John. Thank you. When we're talking about the patient population here, or the population group that people should be thinking about, this next question from Rebecca really tries to get at the granularity of the population. How specific or general should that population be? What are some of the characteristics of the population groups that people should be identifying?
Well, I'll take this, but then maybe Catherine can weigh in a little bit. Let me just say this. First of all, it's good the way that you wrote that. A single disease is never the way to go, because single diseases, which we should do a good job of managing, a single disease, let's say I have let's say I have hypertension, let's say I have diabetes, let's say I have COPD, but that's it. Those patients really aren't the big consumers of resources. They're many of us, and we're going to consume some resources, but they're not the big consumers. Now, obviously, when you have comorbidities, then you start to have it. The answer, people tend to work, you can work on a specific disease population with lots of comorbidities. That's one approach. But I would say we're not usually that granular. I'd rather have you choose an approach where you say more like, we're working on people with multiple comorbidities, this particular group, but they're not, and they live in the community, but they're not frail elders. Or we're working with some frail elders. Or we're working with people between the ages of 18 and 65 who have significant mental health issues. They are lower socioeconomic status, and they have a set of medical issues too. That's sort of how people think about this. But Catherine, what else would you say?
Yeah, John, I think that's a good start. I would add that we really encourage people, and will help you do this at the beginning of the collaborative, to learn in depth what your data is showing you about where costs lie in your system, and what those, when you look at the profile of people who are in that top 1 to 5%, what are they struggling with, and then allow the data to help you to define that population, because you might have in your mind that it's COPD right now, but we might find when we help you look through the data that it's actually a different group of people who are driving the most of the cost. So we would help you to identify in a tailored way to your population who it's going to make the most sense to target for this enhanced, transformed care.
Great. Thank you very much, John and Catherine. Corey, we've had a couple of questions up here on the board. You've answered it to some extent, but maybe if you could just extrapolate a bit. Some questions about the nature of the team itself. Who really needs, what kind of skill sets need to be on that team?
Yeah, thanks, Stephen. So first of all, leadership support is really, really important, and John talked about this. Leaders don't need to be on the team, but they do need to be engaged. They need to officially sponsor it. They need to understand the work of the team, check in with it regularly, help remove barriers. A lot of this testing is actually trying to understand how do we work outside the walls of our clinic or the walls of our organizations with other community resources that are needed to really create the care model that creates the impact you're looking for. And so leaders may be needed to help create some of those partnerships and remove barriers that will allow maybe innovative, creative, and out-of-the-box testing. So that's one really important piece. I think having good physician or clinician champion and sponsorship is also really important. So having a physician or clinician champion on the team is important. John talked about having what we call this person a day-to-day leader, someone who understands the work that the team will be focused on, someone who is a really good project manager. Even if they don't do the project management themselves, they delegate the more task-oriented things, understanding, what does it take to keep your learning moving along, keep the PDSAs moving along, work with the data people so that you get your measures, make sure that the team, when the team is meeting, that they're looking at the right kinds of things, the PDSAs and the data, and understanding what it is you're learning and what taking the next step, those kinds of things. And from there, to have a multidisciplinary team, so having people that can bring different perspectives of working with patients and the processes involved. So People might have a case manager. If you already have the case management kind of staff, certainly that person would be on there. If you have behavioral health staff, that person probably belongs on there as well. Medical assistants, nurses, and if you, to the extent that you are working with community partners, create a cross-continuum team and put partners on from community resources as that makes sense. John, Catherine, would you add anything?
Certainly someone who's good at working with data is going to be part of the team as well.
Great. Thank you, Corey. That's really helpful. There's another question up here from Health PEI, which really is trying to get at how the work is distributed amongst the team. So the question really is around who should actually attend the various elements of the collaborative, whether it's the bi-monthly calls, the face-to-face meeting. Could you just could you give us a sense of how that work is distributed?
Yeah, this is Corey. I'll jump in here. So first, I'll tackle the learning sessions. The learning sessions, there is some didactic content, but especially after the first one, in the first part of the collaborative, the rest of the time really is about learning. And so the learning sessions are working sessions. Ideally, as many of the team members can come to the learning session as possible and as feasible. That's much easier, of course, when it's virtual than when you have to travel people. But the learning sessions are working sessions, and so as the team is exposed to new ideas and new content, they'll have time and be facilitated in different activities to really move their work along. So ideally, as many team members as possible. I'd say the same thing about the phone calls, and I also know that just logistically it's hard to lever people away from the work that they need to be doing every day. I think at a minimum, identifying, at least one, and ideally 2 to 3 people from the team that can reliably make the phone calls, share the work you're doing, hear the work that's happening in other places, cross-fertilizing ideas that you might want to test, gaining knowledge outside of your own sphere. That kind of thing is would be ideal for the phone calls. We will have a series of measurement calls, and those are specifically for the people working with data.
A quick comment I'd make, and it's going to try to address another question I see there. One of the things we'll do in the very beginning of this work, as you could imagine, the organizations are going to be at different spots. So I'll pick again on Edmonton. Hey, but they've been working on this for a couple of years. They've been making some good progress. Somebody else on the list says they're at 125 at this moment in time. So in order for us to work with systems at various levels, whether they're at 0 or they're at 1,000, what we'll do is we'll actually front load this collaborative with a lot of the key elements that we want people to know about. And that's a way we try to bring everybody up at least to a vocabulary that's the same and some sort of basis as the same. And then just emphasize, then as we move forward, so really in September, October, we'll do a lot of front loading. Then as we move forward after that, then what we really are doing is we're really working with the teams at an individual level as we'll have them share on the collaborative. So a team actually, an organization actually presents and says, here's where we are, and here's our success, and here's our failures, and what's our next step, and we all work together on a particular aspect that is focused on either the design or the recruitment or some component of it. Then the other question that I want to answer is just, because the people are at different places, we'll try to work with organizations. Our goal always in this kind of work is to accelerate the organization. So if a team is stuck at 125 and needs to jump up to the 625, then we will try to help them figure out what the issues are. Generally speaking, just in general, the issues are probably one of 5 things. It's either a workforce issue, or it's a business model issue, it's a financing issue, or there's something about the physical, or there's something about IT. But when I say information technology, you also think data exchanges, data agreements, and all of that, or it's something about the learning system. Because by 125, surely you've got a great model design, you're doing fantastic on engaging people, recruiting people, and you're already working with the community. So then what are the issues that you have? And it's these structural issues. So again, we're prepared. Our goal is to start wherever our team is and help, accelerate them on the way.
Great. Thank you, John. So one other question here on the team, Corey. The recommended size of the team, the number of team members. You kind of went over the skill sets that are required. What's the typical size of the team?
I would say, and Catherine and John may also have experience to jump in here, but I would say the core team that would drive the work, that would really understand what you're trying to accomplish, always look at the data, always understand the testing going on and trying to understand the learning, would be somewhere between 6 to 12 people. If you get much smaller or much bigger, it can lose some of its functionality. If it's much smaller, it can lose some of its creativity that comes from different viewpoints. And if it gets much bigger, it just becomes unwieldy to really manage all the people. That said, you could have a structure where you have a core team and then have some sub-teams doing particular pieces of the work that then connect into the core planning team.
Great, thanks. Yep, John?
One follow-up I want to make to that. One thing you have to recognize is don't think, even though I try to make it fairly straightforward, but you may have a number of initiatives or projects that connect to this in one place. So for instance, one place I'm working with, they have at least 3 pieces of work that connect to a high-risk population. One is they're trying to skill up and improve primary care. 2, they're working very hard on decreasing readmissions to the hospital, and that's a separate project, interrelated with the other ones. And then 3rd, they have a community outreach worker working with high-risk individuals. So you'll have a core team that maybe interfaces with the IHI, but you may have a lot more activity going on that somebody has to be coordinating between. And so just think of this as that you'll have probably several initiatives, not just one thing you're doing that's going to make a difference for this.
Great, thank you. I think that's pretty much the end of the questions. I just want to remind folks that the thing to do next, the next steps here now are to go to our website, take a look at the information that's posted there. There's a link on our website to the prospectus for the collaborative that's on the IHI website. We really encourage you to take a look at that prospectus. Give it a read. You're going to hear, you're going to see in there much of what you heard today, but you'll be able to share that with others in the organization and really think about whether the collaborative is for you or not. And then please send us an email to let us know that you're interested in working with this collaborative, joining the collaborative, and potentially being supported by CFHI. We're going to put up a little poll now. We would really ask you to answer 3 very quick questions at the bottom of your screen. They will really help us to get an understanding of how helpful this call was for you as you consider going into the collaborative. This helps both ourselves and the Institute for Healthcare Improvement as we provide these kinds of informational calls to prospective team members. So please do take an opportunity to fill that out. From the IHI faculty and staff, Corey, Catherine, and John, any final thoughts that you would like to leave the folks with today who are participating?
Yeah, one quick comment I would make, and Corey just said it. Many of you already have some work going on in these areas, so don't think of this particular piece of work as creating a brand new set of projects. You may create some new stuff, but also you'll have some pieces of work that already make sense for these populations or this population. And part of what we're going to try to do is help you tie that together in a better way so that you can accelerate your work.
Yeah, that's a great point, John. This should really be seen as an opportunity to accelerate work that's already underway and an opportunity to do things better rather than trying to take on something else. That's a perennial problem within the healthcare environment. So see this as a vehicle to move things forward and advance things in your organization. And also, I would say as well, both Catherine and John, an opportunity to create new partnerships to really more fully address some of the population health issues that many of these populations that are often required to address the needs of the population. Okay, so with that, I think we will sign off on today's call. I'd like to thank everybody for participating in today's call. We thank you for your interest in the collaborative, and we certainly really look forward to hearing from many of you as we move forward and help Canadian teams to get ready to participate in what we all know is going to be a really tremendous learning process with the IHI. With that,
Go ahead.
With that, we will sign off for today. Thank you.
What?
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.